starting the modules on gastrointestinal disorders in children. The first module is about anomalies of the gastrointestinal tract. We'll start with the first anomaly, that is regarding esophageal atresia. It is a condition wherein there is discontinuity in the esophagus because a part of the esophagus is not formed at all. That is what is called esophageal atresia. Let us look at some of the important associations of this condition. An important association is TEF, which is tracheoesophageal fistula. And this association is noted in 85% of cases of esophageal atresia. So making it the most important associated anomaly in esophageal atresia. Okay. The second important group of anomalies associated with atresia and fistula can be remembered as vectoral association. This vectoral is an expansion for a group of anomaly association. What is that? V for vertebral defects, A for anorectal malformations like anal atresias, C for cardiac defects, and TE is for tracheoesophageal fistula and esophageal atresia, R for renal anomalies, and L for limb defects. This is what is a vectoral association. So always remember, whenever you get a case of esophageal atresia, you have to evaluate for these associated anomalies as well. Now, let us look at the clinical presentation of esophageal atresia. Please remember, this is the esophagus, and let's imagine that there is a atresia here. So what happened? There is a discontinuity of the esophagus. So the child is going to vomit out the milk. Okay. So this child classically present with recurrent episodes of vomiting, and this is obviously non-bilious form of vomiting. That is a usual presentation. Now, in the delivery room itself, you can make a diagnosis. How? This child will have profuse drooling of saliva from the mouth because the child is not able to swallow the saliva, okay, because of obstruction due to esophageal atresia. So, drooling of frothy saliva in the newborn period is also one more indicator of esophageal atresia. Okay, right. And in the antenatal period, mother has a history of polyhydramnios. What is the simple reason? The amniotic fluid has to be swallowed by the fetus in the intrauterine period. But because of esophageal atresia, the amniotic fluid is not fully swallowed and it remains outside in the amniotic sac, causing increase in the levels of amniotic fluid and thereby associated with polyhydramnios. These are the important features of esophageal atresia that you should be aware of. What is an important complication of this condition? When the child is having repeated vomiting, the child can have aspiration of feed, thereby resulting in aspiration of feed or milk into the respiratory tract, causing aspiration pneumonitis. And whenever aspiration pneumonitis is severe, it can even result in the death of the baby also. So this is a common complication which can even result in death in babies with esophageal atresia. Next, you should know about classification of esophageal atresia with tracheoesophageal fistula. You can see that there are 5 types of esophageal atresia with fistula being described, and this classification is called as gross classification. Okay. The types are remembered with the alphabets A, B, C, D, and E. Okay. Now, out of this, some important MCQs are possible. Type C is the overall most common type. What is type C? You can see that this is the E for esophagus, which has become atretic in this area, and you can see the lower part of the esophagus is having a connection or fistula with the trachea. So what is the description of type C? It is proximal or the upper part of the esophagus is atretic. So proximal esophageal atresia with distal esophageal fistula. This is the commonest type of esophageal atresia with fistula. Okay. Next, which is the least common type? Type D is the least common type. That is also an important MCQ question. And final question is, look at that last type, which is type E. Can you see that the shape of that anomaly is looking like the shape of a H, something like this? That is why this is also called as a H-shaped fistula. H-shaped fistula. So remember, it is type E but called as H-shaped tracheoesophageal fistula. Okay, so that is some important one-liners which has been asked regarding the classification of esophageal atresia with fistula. Okay, so now how do you make a diagnosis of esophageal atresia? Very simple. In the newborn period, as a part of routine assessment of newborn, we always put a nasogastric tube to check for the patency, and then if indicated, we may take the X-ray also. In this particular condition, while putting the nasogastric tube itself, you will notice that there is a resistance because the tube cannot pass all the way down into the stomach due to esophageal atresia. And after putting the tube, if you take the X-ray, you will see the classical coiling of the tube in the upper part of the esophagus itself. So the classical diagnostic finding in esophageal atresia is coiling of NGT, that is nasogastric tube, in the upper esophagus. This is the typical diagnostic finding in case of esophageal atresia. Okay. Now lastly, you should know about treatment of esophageal atresia. Remember, this condition is corrected only by surgical repair. And what is that surgical approach? It is posterolateral thoracotomy. You perform posterolateral thoracotomy, and after that you go for the repair of the defects. Why this posterolateral thoracotomy? Because that results in adequate exposure of the esophagus as well as trachea so that the repair can be carried out meticulously. That is why this approach of posterolateral thoracotomy is considered as the approach of choice in cases of repair of esophageal atresia with fistula. That is about the first anomaly of the gastrointestinal tract. Next is about the condition called IHPS, which is idiopathic, or also called as infantile hypertrophic pyloric stenosis. Okay. The name itself is self-explanatory. What is happening, or what is the basic pathology in this condition? There is hypertrophy of muscles in the pyloric region, especially circular muscle fibers are undergoing hypertrophy. And whenever they undergo hypertrophy, what happens? It results in thickening of the muscle fibers, and that thickening is going to cause narrowing or stenosis at the level of pylorus. That is why this is called as hypertrophic pyloric stenosis. Okay, right. Now, this condition is common in male babies when compared to females. 4:1 incidence of male and female is noted. So more common in males, and particularly important association is that the risk of pyloric stenosis is more in the firstborn male baby of the family. That's a statistical association which you should know as a one-liner question. Okay, right. Next important one-liner is some drug association noted in the newborn period. It is usage of macrolides, especially erythromycin usage. Okay. This erythromycin usage either by the mother during pregnancy, especially before delivery, or in the newborn baby within the first 2 weeks after birth, is associated with a statistical association of pyloric stenosis. That is why this drug is usually avoided for any treatment purpose in the newborn period. Okay, now moving forward, let us discuss about the features of pyloric stenosis. As you can see from this picture, there is narrowing in this region due to hypertrophy of the circular muscle fibers. So what is the problem? There is going to be obstruction or stenosis in this area. Okay, right. And because of which all the contents which are coming into the stomach will be vomited out. Okay, so the classical feature is going to be vomiting. Of course, it is a non-bilious vomiting. The typical description of vomiting is that it is a forceful vomiting and a projectile vomiting. And this usually occurs after feeds. Okay, after the feeds, the child keeps on vomiting, okay, due to obstruction or narrowing at the pylorus region. Very simple. This is the important point. Vomiting in pyloric stenosis does not start immediately after birth. It usually starts 2 to 3 weeks after birth. Okay. Very, very rarely only it starts immediately after birth, but for all practical purposes and for your clinical scenario questions, please remember this. It's vomiting usually starts 2 to 3 weeks after birth. Okay. This very fact can help you in ruling out or thinking about possibility of pyloric stenosis in a baby presenting with repeated vomiting episodes. So do make a note of it. The next important feature is because the obstruction is at the level of pylorus, there would be distension proximal to that obstruction. Or in other words, you will have a swelling in pyloric stenosis, and the classical location of the swelling is epigastric swelling. Okay, which is the region above the umbilicus, epigastric swelling. Okay. And the classical shape of the swelling is olive-shaped swelling. Okay, and this swelling is usually noted after the child has vomited. That is a classical description of swelling in case of hypertrophic pyloric stenosis. Another important feature is there is narrowing at the level of pylorus. So what happens? There is a increased peristaltic activity which is happening in order to overcome the obstruction. And this increased peristaltic activity in the presence of swelling gives rise to visible peristaltic activity when you see the baby. So this is called as visible gastric peristalsis, which is noted after feeding. And the usual direction of peristalsis is from left side to the right side. Okay, these three are classical hallmark features of hypertrophic pyloric stenosis. Okay, next important is an associated feature in pyloric stenosis, which is jaundice. Okay, and this jaundice association is attributed due to decreased activity of the enzyme UDP-GT. We all know that UDP-GT is an important enzyme for conjugation of bilirubin. Because that activity is decreased, there is increased unconjugated bilirubin contributing to jaundice in these cases. And the association of hypertrophic pyloric stenosis with jaundice is called as icteropyloric syndrome. Ictero refers to the jaundice and pyloro refers to the pyloric stenosis. So it's called icteropyloric syndrome. Okay, now let us move on to investigations which can be done in a case of pyloric stenosis. First, you can take a contrast X-ray. After giving that barium contrast, what you can notice? You can notice that the contrast is filling up the stomach. However, in the area of pylorus, this is the area of pylorus, you see that there is a narrowing. Okay, can you notice that this narrow area, that narrow area corresponds to the pylorus, which has become very small due to that stenosis caused by hypertrophy of pyloric muscles. And this sign is called as string sign. Okay, that narrow pyloric channel is called as string sign. The next sign is the barium or the contrast tracks through the sides of that narrow pyloric channel. Something like on the sides of the pyloric channel it tracks through, creating a double track sign. Okay, double track sign. Third important sign is the hypertrophic pyloric muscle bulges into the gastric antrum like this. Can you notice that? This is called as the shoulder sign. And there is also one more sign which is described. What is that? The hypertrophic pyloric muscle can bulge on the other side. What is that on the other side? It is a duodenum. So it can bulge into the duodenum like this. Okay? And that duodenum would continue like this. This is something like the mushrooming in this area. Okay? Can you understand? Okay, so mushrooming is created by bulging of the hypertrophic pyloric muscle into the first part of duodenum. So the name itself is called as mushroom sign. These are some of the named signs which you can get while doing the barium meal or contrast X-ray in case of pyloric stenosis. Now, if there is a question, what is the imaging modality of choice or the investigation of choice, then your answer is going to be ultrasound. This is the investigation of choice. What can you see? You can see the arrow pointing towards the enlarged or hypertrophied pyloric muscle here. Can you notice that? This is the pyloric muscle on one side and the pyloric muscle on the other side here. As a result of which, the pyloric channel, what I am marking now is the pyloric channel, has become very, very narrow. And there is a criteria for diagnosing pyloric stenosis by ultrasound. What is that? Thickness of the pyloric muscle is more than or equal to 4 millimeter, and length of the pyloric channel is more than or equal to 16 millimeter. That is the diagnostic criteria by ultrasound in cases of hypertrophic pyloric stenosis. Finally, about the treatment of pyloric stenosis. We all know that it's a surgically correctable condition, but before you proceed for the surgery, you have to manage dehydration. Very important, these children have repeated episodes of vomiting, so they go in for dehydration. That has to be managed. Not only that, these children, in addition to dehydration, will have electrolyte imbalances. That also has to be managed. So first, let us study about what are the electrolyte imbalances they have. Very simple. These children are going to vomit out the contents which are entering into the stomach. What is going to be vomited out? The feed, the milk is going to be vomited out. Next, the content of the stomach itself is vomited out. What is that? Hydrochloric acid. That is going to be vomited out. So H plus is out, Cl minus is also out. That is the content of hydrochloric acid, right? H plus and Cl. So when it is vomited out, you will get hypochloremia with metabolic alkalosis. Okay, so hypochloremic metabolic alkalosis. Another important point is the mucus, which is also a secretion of the stomach, is going to be vomited out, and mucus is rich in potassium. So when that is going to be vomited out, there is loss of potassium as well, resulting in hypokalemia. Okay, so hypokalemic, hypochloremic, metabolic alkalosis. Now what happens when the vomiting goes on for a long period of time? At one point of time, child also develops hyponatremia. Now what is going to happen? The kidney will try to conserve sodium ion because of the condition of hyponatremia. So kidney, I'm talking about the tubules, renal tubules, they will reabsorb sodium. Please remember, sodium is a positive ion. When a positive ion is reabsorbed, to maintain the electron neutrality, the tubules have to secrete back a positive ion. Okay, the positive ions which are secreted in this condition includes H plus, as well as K plus. So what happened? H plus and K plus, once they are secreted, they will be excreted in the urine. Are you able to follow this? So you can see that K plus is getting excreted. That contributes again to hypokalemia, and also H plus is getting excreted. So what happens to the pH of the urine? It turns acidic due to H plus. This is not a normal reaction expected. Why? Because whenever there is alkalosis, the kidney has to conserve H plus. But here, paradoxically, the kidney is excreting or secreting H plus in the urine. That is why this condition is called as paradoxical aciduria. Okay. So these are the important electrolyte abnormalities. Again, quickly going through: hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. This is the complete electrolyte abnormality noted in pyloric stenosis. So as I was telling you, you should correct dehydration. For dehydration, you are going to use IV fluids. You can either use half normal saline with added potassium as an IV fluid, or you can use ringer lactate as an IV fluid. Remember, normal saline doesn't contain any potassium. That is why added potassium is very important here. But ringer lactate can be used as such because ringer lactate contains additional potassium. Okay. So first step in the management is always correction of dehydration using IV fluids. After dehydration is corrected, you go for the surgical treatment. And what is the surgical treatment of choice? It is pyloromyotomy, and the complete name is Ramstead pyloromyotomy. That is the final treatment in case of hypertrophic pyloric stenosis. Remember, pyloric stenosis is a very, very important topic, repeatedly asked in your exam, so make sure you know all the points about pyloric stenosis. The next condition I am going to discuss about is called duodenal atresia, wherein there is a problem in the continuity of duodenum. Very simple. Okay. And if you look at the basic pathology of duodenal atresia, it is due to failure of recanalization of duodenal lumen. Let me explain it in detail. Normally what happens in the intrauterine life, when the duodenum is getting formed, it is not patent. As the gestation proceeds, there will be recanalization of the duodenal lumen, thereby the duodenal lumen will become patent. When this recanalization process does not occur, the duodenum will not be patent, and that is the condition of duodenal atresia. So that is what I have written as a summary: failure of recanalization of duodenal lumen during development. Okay, right. Now an important genetic association for duodenal atresia is for Down syndrome. Please recollect the important point. What is that? In Down syndrome, the most common anomaly is the heart defect. I told you endocardial cushion defect. But the second most common group of anomaly is the gastrointestinal anomaly, and in GI anomaly, most commonly it is duodenal atresia. Okay. Remember, 30% case of Down syndrome are associated with duodenal atresia as an association. This is an important point. Other important associations are prematurity. 25 to 50% cases have prematurity. And other associations are congenital heart defects, which is observed in 30% of cases. These are the other significant associations for duodenal atresia. What is the characteristic feature of duodenal atresia? Again, duodenal atresia is causing obstruction at the level of duodenum. So this child is also going to present with vomiting. But here it is bilious vomiting, indicating that the level of obstruction or atresia is below the opening of the bile duct into the duodenum. Very important point. Okay. So bilious vomiting is a hallmark feature, and the bilious vomiting will start at birth itself, or soon after birth itself it will start. That's an important point. Usually this is not associated with abdominal distension. That is also an important feature. Not associated with abdominal distension. Okay. And maternal history will be significant for polyhydramnios. Again, the same reason. What is that? There is obstruction in the intestine. So the amniotic fluid is not fully swallowed, remains inside the amniotic cavity only, resulting in increased amniotic fluid. Okay. And we all know the classical X-ray finding in case of duodenal atresia. What is that? It is a double bubble appearance, or the double bubble sign. Can you notice the first bubble is in the stomach and the second bubble till the level of obstruction in the duodenum? That is what is a double bubble sign. Please remember this important point, that double bubble sign is not only seen in case of duodenal atresia, it is also seen in cases of conditions like annular pancreas. In annular pancreas also, what happened? The annulus surrounds the duodenum and constricts it, causing a condition similar to duodenal atresia. That is why double bubble sign is also seen in that condition. In duodenal web also double bubble sign is seen. So these are the other condition where you can get a double bubble sign. So if they ask you what is the important or diagnostic modality in children with duodenal atresia, you either have to use an ultrasound for diagnosis or a CT imaging. This is the usual diagnostic modality in case of duodenal atresia. Finally, what is the treatment for these children? It is again surgical correction, where you remove the atretic part and join the remaining parts of duodenum, or anastomose the remaining parts of duodenum. What is that? Duodenostomy. That is the treatment of choice in cases of duodenal atresia. So that is about the topic of duodenal atresia. Next, moving on to the most common anomaly of the GIT, and that is Meckel's diverticulum. It is seen in 2% of world's population, making it the most common GA anomaly. Okay, what is a basic pathology in Meckel's diverticulum? Remember, it is a remnant of a duct called as omphalomesenteric duct or vitellointestinal duct. This omphalomesenteric or vitellointestinal duct is a fetal communication between the abdominal wall at the level of umbilicus and the small intestine. What happens? Normally, by the time of birth, this duct should have completely disappeared or obliterated. If it is patent on the intestinal end, you will get Meckel's diverticulum. So that is why I have written it as a remnant of omphalomesenteric or vitellointestinal duct. Okay. Now, Meckel's diverticulum is a true diverticulum, meaning that all the layers are present. That is why it's called as a true diverticulum. Okay. And some important features of Meckel's diverticulum can be remembered by the rule of 2. Okay. What is that rule of 2? I have said already that it is present in 2% of world's population. Second, the length of the Meckel's diverticulum is 2 inches or 5 centimeter. Next, the location. It is 2 foot from the ileocecal junction, and where exactly it is located in the ileum? It is the anti-mesenteric border of the ileum. Anti-mesenteric border of the ileum. That is the next two which you have to remember. Third important two is that it is lined by two types of ectopic mucosa or heterotopic mucosa. Or in other words, what I am trying to tell you is that it is lined by a mucosa which is different from the normal intestinal mucosa. What are those two ectopic mucosas? One, it is gastric mucosa, and the other is a pancreatic mucosa. So these are the two types of ectopic mucosa present as a lining in Meckel's diverticulum. Okay. Next two is that it is 2 times more common in females compared to males. Okay. 2 times more common in females. Okay. Right. Now, most of the cases of Meckel's diverticulum is asymptomatic. The child does not usually present with any features. So more often it is usually detected as an incidental finding. For example, when you open the abdomen or do surgery in the abdomen for some other reason, at that time you may find the Meckel's diverticulum. So that is what it is, an incidental finding, or in other words, most of the cases are asymptomatic. Okay, right. However, if the children are going to have symptoms, the symptoms start before the age of 2 years. That is also one more point for rule of 2. Symptoms, if at all, going to be present before the age of 2 years. And what is that symptom be? It is painless rectal bleeds or painless bleeding at the time of stool passage. That is what I mean by painless rectal bleed. What could be the reason for the bleeding? The bleeding is due to bleeding from deep ileal ulcers. Ulcers in the ileum. What is the reason for ulcers forming in the ileum? Very simple. I was telling that this Meckel's diverticulum is lined by ectopic gastric mucosa. They will start secreting hydrochloric acid, and that hydrochloric acid causes ulcers in the distal part of the ileum. Okay. When the ulcers become deep, they will have the manifestation of bleeding from the ulcer, and that is going to come out as blood in the stools. That is why these children can present with painless bleeding. Okay. And the characteristic of that bleed is a current jelly bleeds or current jelly stools. It is also called by other names like melanotic bleeds or maroon bleeds. These are the alternative names for bleeding associated with Meckel's diverticulum: current jelly stools or current jelly bleeds, melanotic bleeds, and maroon bleeds. These are the characteristic type of bleeds associated with Meckel's diverticulum. Okay, right. This is the usual presentation. Other rare forms of presentation would include intestinal obstruction. The reason for intestinal obstruction is because the Meckel's diverticulum can act as a lead point for intussusception, and this can be associated with ileocolic intussusception. As I have already said, this is a rare presentation. However, the MCQ question for you in the exam is intestinal obstruction due to intussusception is the most common presentation in case of adults. That point should not be forgotten. Okay. Another rare presentation is that it can have a volvulus type of presentation. What is the reason for this volvulus? Think like this. This is that ileum which we are talking about, and this is the Meckel's diverticulum which I am drawing here, and this is the umbilicus. Okay, sometimes what happens, there is a fibrous band which is connecting this umbilicus and the Meckel's diverticulum. And what happens, this Meckel's diverticulum can have a twisting moment around that fibrous band, and this can predispose to the development of volvulus. Okay, right. This is again a rare presentation. Okay. Third important rare presentation is that Meckel's diverticulum can form a part of the hernial sac. In that case, that hernia is referred to as Litter's hernia. Littra, Litter's hernia. This description of Litter's hernia has been asked in one of the competitive exams. Okay, so these are the different ways by which a Meckel's diverticulum can present, but the summary is most cases are asymptomatic, and if at all they are symptomatic, the usual symptom is painless bleeding in the stools. Okay, moving on to the diagnostic investigation in Meckel's diverticulum. It is Meckel's scan, or what we also called as the radionuclide scan, which is 99 technetium per technetate scan. Okay, have a look at that picture. Okay, the areas which are dark black in color is the area of radionuclide activity. Can you see in all the pictures there is dark color here, all these areas? That is the area of stomach, because this radionuclide, that is 99 technetium per technetate, has an affinity for gastric mucosa. Okay, and I have said that Meckel's diverticulum also has ectopic gastric mucosa. That is why, can you notice one more area where there is dark black coloration? This area, can you notice it here? That dark area corresponds to the area of Meckel's diverticulum, because Meckel's diverticulum also has ectopic gastric mucosa, and that will take up the radionuclide activity. Okay, that is why you are getting additional radionuclide activity in the area of Meckel's diverticulum. Okay, so the investigation of choice is Meckel's scan, which is a 99 technetium per technetate scan. What is the treatment of Meckel's diverticulum? Remember, asymptomatic Meckel's diverticulum are usually detected as an incidental finding. So, when should you make a decision to treat Meckel's diverticulum if it is noted as an incidental finding? First point is that if the Meckel's diverticulum has a narrow mouth or a narrow base, you have to do the surgical excision by diverticulectomy. On the other hand, if the Meckel's diverticulum has a wide mouth or a wide base, you can leave it as such, provided the patient is asymptomatic. At any point of time, the patient has symptoms or a symptomatic Meckel's diverticulum, always you have to perform diverticulectomy. This is the current consensus regarding management of Meckel's diverticulum. The last anomaly in the gastrointestinal tract I am going to discuss is Hirschsprung disease, which is also called as aganglionosis, because of absence of ganglions in the intestine. We usually know that ganglions are present in the intestinal wall, which layers submucosal and the muscular layers, which we call it as Orbach plexus and the Meissner's plexus. That is going to be absent in case of Hirschsprung disease. So the basic pathology is absence of ganglion, and the reason for this absence of ganglion is due to failure of migration of neurons during development. So this is basically a neuronal migration disorder. And it gets a special name as neurocrystopathy. Okay, now let us see what is the consequence of absence of this ganglion. The result is there is failure of relaxation of the intestine. I am talking about the intestinal smooth muscles, they fail to relax. Normally, remember, whenever the stool is coming, the intestine has to relax. only then stool can pass through that segment of the intestine. In this condition, there is failure of relaxation, or in other words, the intestine always remain in a constricted state. So what happened? The stool is not able to pass through that aganglionic segment of the intestine. I hope you are able to follow this. So that is why in this condition, the stools will be stuck in the intestine proximal to the affected area. Okay, this is the basic pathology in case of Hirschsprung disease. Let us look at some more important data about Hirschsprung disease. This is a condition which is more common in male-female ratio is around 4:1. Okay, male-female ratio is around 4:1. And the site of intestine affected most commonly is the rectosigmoid. Okay, this is the area affected in 80% cases of Hirschsprung disease. And rectosigmoid involvement is also called as a short segment disease. Because only a small area is affected, we call it short segment disease. In 15% of cases, you get a long segment disease, wherein areas proximal to sigmoid, that is a transverse colon, can get affected. That is called long segment disease. And in 5% of cases, the entire colon is getting affected. This is called as a total colon disease. Okay, that is 5% of the cases. But for all practical purpose and for your exam questions also, you will get cases of rectosigmoid type of Hirschsprung disease only, because that is the most common overall variety of Hirschsprung disease. Some of the important associations include Down syndrome, and another important genetic defect associated is mutations in RET proto-oncogene. These are some genetic associations that one should be aware of in Hirschsprung disease. What would be the clinical features of Hirschsprung disease? As I said, there is failure of relaxation of the affected segment of the intestine. So think like this: rectosigmoid area is always in a constricted state or it fails to relax. So what happens? In a newborn baby, the meconium cannot pass through the rectosigmoid region. Thereby, meconium is not able to come out, or these children present with delay in the passage of meconium. That is, even after 48 hours of birth also, they don't have a passage of meconium. That is what is the main feature of Hirschsprung disease. And because the meconium is getting retained inside the intestine itself, there would be abdominal distension. Okay, in older children, the presentation is with constipation. Very simple, because the stools are not getting passed, they will present with constipation. Okay, and in these children, if you do the rectal examination, you will feel that the rectum feels empty because the stools have not come into the rectum because of failure of relaxation. Okay, and what happens on withdrawal of the examining finger, there will be a sudden expulsion of meconium. It is very simple to understand this. How? When you put the finger inside, you are transiently dilating the rectum, okay, by putting the finger inside. Now what happens? This will create space for that stool to come inside. And the moment you take out your finger, all the meconium or the stools will come out. That is what I mean by sudden expulsion of meconium on withdrawal of the examining finger. Okay, That is the finding in case of rectal examination. Next, you have to proceed for investigations. The first investigation which we can do is rectal manometry to look for changes of pressure inside the rectum. Okay, and a classical finding in rectal manometry is absence of recto-anal inhibitory reflex. You must have studied about this recto-anal inhibitory reflex in your physiology classes. What mediates this recto-anal inhibitory reflex is the ganglions. What happens in Hirschsprung disease? The ganglions are absent, so this reflex will not be elicited. That is the usual finding in case of rectal manometric examination. Okay, and if there is a question, which is the best investigation for diagnosis of Hirschsprung disease, your answer is rectal suction biopsy. This is the best investigation or the investigation of choice in case of Hirschsprung disease. So what are you going to get in this rectal biopsy? You will get hypertrophy of nerve fibers, absence of ganglion, and you will do a special staining to look for acetylcholinesterase activity. I'll show the picture here. All these brown colorations which you see in this picture is a special staining for acetylcholinesterase activity, and you can notice that there is an increased staining for acetylcholinesterase, or in other words, there is increased acetylcholinesterase activity in this condition. That is one more important diagnostic clue to the presence of Hirschsprung disease. So not to forget, rectal biopsy is the investigation of choice in case of Hirschsprung disease. Last is about the treatment of Hirschsprung disease. Remember previously, resection and anastomosis was done. What you do? You resect the part of the intestine which is not having ganglion and anastomose the remaining parts of the intestine. However, that is not the procedure which is done nowadays. What is now done is called as a pull-through procedure. Okay, what is this pull-through procedure? You pull that normal part of the intestine through the aganglionic part and attach it to the last part of the intestine, that is the anus. That is what is called as a pull-through procedure. There are two important names of this pull-through procedure. One is the Duhamel's procedure, other one is the Soyas procedure. And Soyas procedure is the preferred procedure in case of Hirschsprung disease. What you do in Soyas procedure, first you strip the rectal mucosa. Remember, rectum is the affected area, so you strip the mucosa of the rectum. Then what you do, you leave behind the muscular parts of the rectum. Can you see that? That is what is written as the muscular cuff. Muscular cuff is essentially the muscular layers of the rectum which are spared and left behind. Why? It is important because when you are pulling the proximal part of the intestine and trying to attach it to the distal part, this muscular cuff provides a support for the intestine that is coming through. That is why you are retaining the muscular part of the rectum while stripping off the mucosa of the rectum. Okay, and this procedure is called as the Soyas procedure, and that is the preferred procedure nowadays for treatment in Hirschsprung disease. So that is about the discussion of Hirschsprung disease, and with that I complete the module on gastrointestinal anomalies in children.